Thank you for the organizing committee for the invitation. So my talk will be about GVHD 2025, new predictive biomarkers and treatment algorithm. I will initially just show you why we have to do better in terms of GVHD treatment and what are the current predictive biomarkers based on the 4 or 5 layers of GVHD that can be used in the prediction. And then we'll show you an update related to the treatment algorithm. So why GVHD still matters? This is from the CIBMTR 2024 from Pasquini. As you can see, the GVHD continue to remain a leading cause of non-relapse morbidity and mortality after allotransplant. It constitutes the about 9 to 10% of mortality before 100 day and after also 100 day of transplant. And this is more common or seen more in the adult population compared to the pediatric population, just to the fact that we use more of peripheral blood stem cell transplant compared to bone marrow harvest in the pediatric populations. What comes first here, as you can see, the dark blue line, color is the primary disease for the more than 100-day post-transplant, and then the organ failure and the infections and GVHD come around 9 to 10%. So early responders to GVHD, they have significantly better overall survival and relapse mortality. And this is shown in this slide. If you look at the overall survival, you will see those patients who had responded to the GVHD treatment by day 28, they have a much better overall survival compared to the patients who respond late. So this is, I would say, clinically critical in predicting who will respond and who will not respond, and that's why or maybe where the biomarkers come here and become clinically suitable to use. The same thing is also for the non-relapse mortality. As you can see, the early day 28 responders, they have a much lower relapse mortality compared to the late responders. So can we do better? Just to review the biology of GVHD, as you can see, when a GVHD occurs, usually it goes through multiple barriers. And you don't have to wait until the patient has already passed all the barriers of active GVHD to start treatment. You need to kind of try to get what are the early signs of something wrong is happening in the patient. So usually, typically what happens is the epithelial dysfunction starts first. This is an example from a gut GVHD. And then an inflammatory reaction will happen where the different inflammatory cells will be recruited to the area. This includes T cells, alloreactive T cells, macrophages, neutrophils. Subsequently, there will be endothelial dysfunction, which usually a later sign of GVH. And that's why you see in patients with severe GVH or multi-organ GVH, they will develop endothelial kind of a syndrome, which include transplant microangiopathic TMA or transplant-associated TMA. So that's why the acute or chronic GVH are usually risk factors for development of post-transplant TMA, because endothelial dysfunction usually is a late sign or a late manifestation of acute GVH. And lastly will be the microbiome disruption that happens, and that would be kind of the last part that lead to in the biology of GVHD. So based on that cartoon, we can classify the GVHD biomarkers into 5 major classes. The first one is the plasma biomarkers, which include the epithelium, as I showed you in the previous slide, and the inflammatory cells. The representative examples are the two important biomarkers which constitute now what we call it the magic algorithm probability, which I'll discuss in the next slides. Those are the two important biomarkers to know about, the ST2 and the REC3A. And we have other plasma biomarkers under the epithelium and inflammatory cells, like the soluble tumor necrosis factor receptor alpha, interleukin 6, and CXCL9 and 10. And as I said, they reflect systematic inflammation and epithelial tissue injury, and they are currently used in the risk stratification and prediction of steroid resistance and relapse mortality. The second major class is the cellular immune markers, which reflect the loss of immune tolerance in JVH and the effector skewing. One example is the Treg-TF ratio. As you know, in GVHD, we have this ratio disrupted. Typically, you prefer to see higher Treg-TF ratio, but if you have low Tregs and high TF ratios, TF cells, usually this is a bad sign of an active JVH. Same thing goes for natural killer cells. Recovery in acute JVHD setting typically indicate unbalanced immune system, which is seen in patients with active JVH. The third major class is the endothelial and the vascular markers. We have three major biomarkers, the Ang2 and the soluble thrombomodulin and the von Willebrand factor. And they reflect endothelial activation and microvascular injury. And they identify patients who are very high risk for multi-organ failure from JVHD, and they can be used as an adjunctive risk modeling. The fourth major category is the microbiome and metabolics, and they reflect usually barrier integrity and immune hemostasis disruption. Typical loss of the normal microbiome is an adjunctive sign of, or maybe it's another kind of risk predictor for gut JVHD. That's why maybe there is, for example, lots of talks about the use of prophylactic antibiotic in transplant, because it may disrupt the microbiome and increase the risk of acute JVHD. And the last one are the genetic factors, and those are pre-transplant, so this is before JVHD occur. We'll discuss them in another slide, but typically related to non-HLA immunogenetics. For example, if you have two patients, same age, same sex, they receive the same conditioning, they have the same diagnosis, but one of them develop JVH and the other does not develop JVH. And that's could be the reason is the underlying genetic factors. So as I showed in the previous slide, this is just an expanded slide for the key plasma biomarkers in JVH. The first two are the two major ones that are the core component of the MAP score for risk stratification. You can see the rest and their clinical significance in JVHD and their clinical use. The single-cell immune profiling, as I showed them in the previous slide, the Treg-TF ratio, the alloreactive T-cell chronotype, and this is interesting. Sometimes in patients with JVHD, if you have, typically you will have alloreactive T-cells, attacking the recipient. And those specific clones, they can multiply and they can expand and persist in the recipient, leading to more damage and more active JVH. Inflammatory versus exhausted T-cell states. This means if you have a patient with a JVHD who has a more of inflammatory T-cell state, he will be having a higher risk compared to those who have exhausted T-cell state. Both they can have JVHD, but those that they have inflammatory T-cell state are at higher risk of having more damage. So it's like an inflammatory phenotype specific for specifics of inflammatory phenotypes of T cells. The tissue-resident immune cells, this is interesting. Sometimes the specific tissues like skin and gut, they have very distinct tissue-specific immune signatures that attack that specific tissue. And that something interesting to know. I don't know, maybe later we could have like an earlier tissue that can detect a specific marker inside the tissue and can be maybe helpful in prediction of steroid resistance and outcome of that patient. Moving to the next category, the endothelial injury markers, the Ang2 and the soluble thrombomodulin and the von Willebrand factor. Those are the biological processes reflected by those biomarkers, as you can see. As I mentioned, typically endothelial injury is a late sign and indicative of severe GVHD and steroid resistance and non-relapse mortality. So if you're able to detect those biomarkers, any patient at, like, let's say, at the beginning of GVHD, which is very unlikely, but maybe at a later stage, like 7 days after GVHD, that's usually tells you that the patient likely will progress and you need to have a different approach rather than waiting or giving a standard of care of treatment for second line. And then we have the microbiome and the metabolics biomarkers. I briefly discussed them in the previous slide. Those are the features: reduced microbial diversity, SCFA producing bacteria, and bile and metabolism, tryptophan AHR pathway, and the microbial derived metabolites. Most of the microbiome biomarkers are still at research phase, not clinically yet used in the clinical trials that are focused on biomarker assessment in GVHD. And the genetic and the polygenic risk in GVHD, as I mentioned, the non-HLA immunogenetics, but you have other reasons why specific patients, because of genetics, they can have different outcomes and different severity of GVHD. And this slide summarizes those genetic factors that can have different outcomes in different patients. Okay, so lots of talks about biomarkers and biology. Now how this can be translated into clinical practice. So now we have something called magic algorithm probability. It has been there for a while. I don't think I didn't use it myself, but because you need to send it to a reference lab, and which we don't have it at the current time. But what is it exactly? It's a biomarker-based risk model developed by the MAGIC consortium and integrate the two biomarkers I mentioned under the plasma markers category, the ST2 and the RIC3A. And what it does, it can predict steroid resistance and non-relapse mortality in acute GVH. And it's used clinically now for risk stratification at GVHD onset and in biomarker-driven trials. It can guide you for early escalation versus standard therapy decision. This is just how it is mathematically calculated by the research labs. So it's a logarithmic kind of equation that gives you a result, and then that result can classify the patient into low risk, intermediate risk, or high risk based on the MAP probability. So there are multiple studies that looked at MAP, or the magic algorithm probability. So it's very well validated across multiple studies in both adult and pediatric population. As you can see here, very interestingly, even within the same clinical response category, like within the patients who responded, and within those who did not respond to acute GVHD treatment, like steroids, you can still classify patients into those who have higher non-relapse mortality, lower relapse mortality, based on the MAP. So it's very excellent, I would say, way to categorize patients early, regardless of how they will respond to treatment. As you can see in the bottom of the slide, the usual grading of acute GVHD was not able to do the same categorization of patients based on into higher or lower non-relapse mortality based on the grading per se. So it is superior to clinical grading of acute GVHD clearly in this clinical trial. This is another trial published last year or about last year, 1 year and a half in a transplantation journal, the MAGIC algorithm probability predict treatment response and long-term outcomes to second-line therapy for acute GVHD. What's interesting here also that MAP not only predict outcome, as you can see, but also appear to identify which patient benefit most from ruxolitinib in steroid refractory acute GVHD. If you look at the right side slide that include the right part of the slide that include the ruxolitinib, even for those who received ruxolitinib and has high MAP, they have still very high incidence of non-relapse mortality. And if you compare those to the patient who had a low MAP but did not receive ruxolitinib, actually that patient had a lower non-relapse mortality. So it's very effective in terms of identifying the risk of progression mortality in GVHD patients. The same is true for pediatric population. It was also studied in pediatrics and was able also to categorize patient into high non-relapse mortality and low non-relapse mortality based on the MAP score. So what would be the framework then in 2026 or maybe in the next few years? Probably what you will have is when you have someone with acute GVHD, the algorithm might shift it to low risk, intermediate risk, and high risk. So who are those low risk? Low risk if you have a favorable MAP, low MAP, you have limited organ involvement. In that patient population, you can just use steroids and you can taper steroids early without worrying much about second-line agents. If you have intermediate risk, for the intermediate risk, you will have intermediate MAP and rising inflammatory or endothelial biomarkers. In those population with intermediate MAP score, steroids plus early add-on therapy might be better compared to waiting for steroid to fail in likely a significant proportion of patients in this category. And then you have the high-risk patients who are the one who having high MAP, so they have multiple barriers involved in GVHD, including the epithelium, the inflammatory, the endothelial, and the immune dysregulation. Those patients are very high likelihood of steroid resistance and progression. And you need to probably think outside of the box. You may want to start upfront combination therapy early, not only steroids, or if you have access to clinical trials, they can be maybe enrolled in a clinical trial. Because even if they receive steroids and Jakavi, let's say, as a second line, they still have very high non-relapse mortality as I shown in the previous slide. So this is just a workflow. If you have access, you can do early baseline biomarkers for early risk estimation. And then subsequently on day plus 21, day plus 28, you can look at the biomarkers trend, if they are rising or stabilizing or declining. And then once the patient has an acute GVHD, you need to do your risk stratification based on MAP, and then consider how would you make your actions for this specific patient based on the risk stratification. If the patient is low risk, you will go with the standard regimen of steroids and giving the patient enough time and then likely tapering steroid early. Versus if the patient is the intermediate, you will probably do early escalation to second line agent. Or if the patient is a high risk, then you will go with upfront combination from the beginning. So this slide shows you the current traditional NCCN guidelines published, the last published version 3/2025, and it shows you the traditional way of managing acute GVHD. This is for like grade 2, grade 4, starting with the systematic steroids and then waiting for a response. And then if the patient has no response, considered to be steroid refractory, and then maybe he can go for a clinical trial, or you may add another systematic agent. The definitions used by the NCCN, you can see it on the right bottom, how they define patient as a failure, which is waiting for about 7 days of treatment initiation, which may be a bit late. Because probably by that time, significant tissue damage may have happened already in someone who is high risk MAP. So the one I propose might happen in the next few years. So maybe the NCCN guidelines can change to include the biomarkers risk assessment. So at GVHD diagnosis on day 0, you will measure your MAP score, and then you will classify your patient into a low, intermediate, or high MAP, as I shown in the previous slide, and follow the algorithm, the updated algorithm. If it's a low risk, you'll follow the standard NCCN pathway. If the patient is an intermediate risk, probably you do earlier assessment like by day 3 rather than waiting for day 7. And consider early add-on if suboptimal response by day 3. And if the patient is a high-risk MAB, you should not just rely on steroids in the beginning, or even traditional second-line agent, and you may have to consider clinical trials. So that's the end of my presentation. The take-home message is GVHD is biologically heterogeneous, not a single clinical entity. Validated predictive biomarkers, particularly MAP, now enable biological risk stratification. And GVHD management is shifting from clinical grading established disease to predicting disease trajectory. Biomarker-informed algorithms support earlier, more precise risk-adapted intervention, and future progress will depend on integrating those biomarkers with the clinical data and personalizing the GVHD therapeutic strategy. Thank you.